very good attendance. It's Friday morning, but if you see the hall, it's almost full. So our next speaker is Dr. Mohamad Mohty. It seems that he could not make to travel, so it will be a virtual talk. And Dr. Mohamad is very well known in BMT as well as a contribution for stem cell transplant. He is a full professor of hematology and head of the hematology and cellular therapy at Department of Saint-Antoine Hospital, University of Paris, France. And his expertise is in many particular fields relevant to the bone marrow transplant. He is the past president of European Society of Blood and Marrow Transplantation, as well as a past chairman of Acute Leukemia Working Party, and Dr. Ahmed Al-Askar already described his background. So beside taking further time, I would ask that we can open his virtual presentation. Unfortunately, we will not have an opportunity to ask questions after this presentation, but certainly there will be a link for the email. If someone have a question, certainly can write to Dr. Mohamad. Thank you so much. So we'll go ahead for our virtual presentation.
Assalamu alaikum, sabah al-khair. It is my great pleasure and honor to be part of this fantastic event. I'm very sorry I'm not able to join you in person because of another meeting I'm chairing in Paris, the COMI meeting. But I would like to take this opportunity to congratulate Dr. Ahmed Al-Askar and his team for the success of this joint effort with the SSBMT. We started this more than 10 years ago, and I can see now it is really flourishing. So I hope I'll be able to join you next time, but definitely this has become a clear and major event in our field, both of course for the kingdom but also for the whole region and more globally. So as you have seen in the program, my task today is, and this is the spirit of this event, to give you some highlights of the last EBMT 2026 annual meeting. And my task is going to be to speak about the sequencing of bispecifics and CAR T cells in myeloma. And as you probably know, this is really the golden era of immunotherapy in multiple myeloma. Obviously, we can immediately start with the comparison between these two forms of immunotherapy, the cellular immunotherapy with CAR T cells, and I would say the in vivo immunotherapy with bispecific antibodies or T-cell engager. I will not go through the comparison about availability, administration, logistics, pluses, minuses, but also the toxicity. But it is obvious that not all patients will be able to be candidate to CAR T cells. Not all patients can wait to receive CAR T cells, and this is why actually we probably need both. And this is different patients require different treatments. So you would see my talk is not structured about opposing CAR T cells to bispecific, but rather see what are the patient profile who can benefit from this or this. When you look to the pivotal or seminal trials which has established the role of the approved bispecifics, the anti-BCMA1, whether teclistamab, elranatamab, or more recently linvoseltamab, or the commercially available CAR T cells, namely ide-cel and cilta-cel. And you can appreciate that these agents, these treatment tools are really allowing for a relatively important, almost sometimes amazing median progression-free survival or overall survival in patients who received a median of 5 or 6 lines of prior therapies. And this is something completely unexpected in the field of relapse refractory multiple myeloma, where even in the 5th line, you can achieve now stringent CR or even MRD negativity, as it has been shown with the long-term follow-up of cilta-cel. And indeed, cilta-cel is probably the most powerful construct in terms of CAR T cells directed against BCMA. The approval came from this CARTITUDE-1 trial, and we have now more than 5 years of follow-up. And you can see that maybe for some patient, even being in the relapse refractory setting, we have a plateau. And this is the reason why the IMW group, whether the European Myeloma Network, but also the national cooperative groups like the IFM, are actually recommending today, whenever feasible, to use or to prefer CAR T cell therapy first in the relapse refractory setting. But you are all familiar with the fact that CAR T cell therapy is logistically complex, and the patient characteristics can impact, and the disease can impact the outcome. This is why patient selection is key. We have the issue of disease risk burden. We have the aggressiveness of the relapse, the age, the comorbidities, the waiting list, and of course, some now newly described long-term toxicities like the Parkinsonism, like in cilta-cel. But one thing for sure is that if you are able to get CAR T cells, bridging therapy is crucial. It's a fundamental step, because those patients who are able to respond to bridging, to have a deeper response, are the patients who are going to enjoy the longest survival, the best outcome, but also they are going to have less complications. And for instance, when you consider the delayed neurotoxicity and non-relapse mortality, actually, when you have patients who are non-responding, they are not responding to the bridging therapy, this is where you have an increased risk of complications. And actually, in this analysis presented last year in multivariable analysis, the Parkinsonism risk is depending on the disease progression versus response to bridging, but also on the rate of proliferation of the CAR T cells. So today, if you look to the treatment algorithm, you can appreciate that these CAR T cells are really positioned almost everywhere in those patients treated and relapsing after an anti-CD38 antibody, whether they are refractory to lenalidomide or to bortezomib or not. So clearly, you have a very high level of evidence, even in early relapse, and we owe this to the CARTITUDE-4 trial, which has shown a PFS advantage, but also an overall survival advantage when compared to the standard of care in 2-line or plus, so means early relapse refractory multiple myeloma. And why people are recommending to use CAR T cells first? Well, actually, and from a patient perspective, actually, CAR T cells can allow for treatment-free interval, but also improvement in global health status and physical functioning with delayed symptom worsening. And this has been very nicely described and is well established. Of course, if you use them early, and here we have a comparison, for instance, with CARTITUDE-1 and CARTITUDE-4, late relapse versus early relapse, actually clearly when you use them early and the patient are less advanced, obviously you have lower incidence and severity of some complications, especially the neurological events. When it comes to bispecific antibodies, again, you have seen very recently since the last ASH 2025 annual meeting that they are coming strong, especially the combination of teclistamab and daratumumab. So teclistamab is a bispecific directed against BCMA, and this so-called Majestic-3 trial has shown some incredible results. You have the summary of this phase 3 randomized trial already published in the New England Journal of Medicine by Dr. Mateos and colleagues, but you can appreciate something around 83% progression-free survival at 3 years. And you can see the shape of these curves is quite elegant compared to the classical standard of care. And we're talking here about patients who are in 1 to 3 prior line of therapies. One important remark is that these patients are treated with daratumumab plus teclistamab, but they were not exposed or refractory to daratumumab. And this is something crucial because we know that today, majority of our patients frontline are receiving induction with an anti-CD38 monoclonal antibody, whether Dara-VRd, Dara-RD, isatuximab VRd, and so on. So we have to figure out the patient profile for these for this combination of Tec-Dara, but clearly, if you look to the different subgroups, all subgroups of the patient are going to take advantage of this combination. And at the end of the day, you can also see an overall survival advantage. So this is transformative, I think, in the field of multiple myeloma, where even at relapse, now probably my best guess, personal opinion, that we will be able to allow patients at time of relapse maybe to envision a cure. Having said this, we have to pay attention when it comes to bispecific antibodies to toxicities. We've spoke a lot about CRS and ICANS, but actually with bispecific, they are less severe compared to some cases of CAR T cells. The issue with bispecific is mainly about the infectious complications, because we know when you target BCMA, actually you are creating a status of hypogammaglobulinemia, and these patients are going to develop many infections, and the use of immunoglobulin substitution is mandatory. Obviously, this Majestic-3 trial was done during the COVID-19 pandemic, so hopefully these infections will be lower when we will start using these agents. But if for whatever reason your patient is refractory to anti-CD38 and IMiD, actually we have a trial, a so-called Majestic-9, which will be presented and published hopefully soon, which used teclistamab single agent as a bispecific in early relapse compared to PVD, pomalidomide, bortezomib dex, or KD, carfilzomib dex, two classical regimens. And we know that the primary endpoint in this trial has been met, and there is a clear benefit for using the bispecific antibodies very early. So in summary, I hope that you are convinced now that the BCMA targeted therapies will become, they are already there, the new standard of care for the management of early relapse. I focused on bispecific and CAR T cells today because that was the title that was given to me, but we should not ignore that we have a similar study with an antibody drug conjugate, belantamab, directed against BCMA, the DREAM-7 trial, which showed that Bela-VD, belantamab bortezomib dex, is superior to daratumumab vel dex. For CAR T cells, in terms of commercial CAR T cells, probably cilta-cel is the strongest construct with the caution about some delayed neurotoxicities. When it comes to the bispecifics in early relapse, the results of Majestic 3 are quite incredible. So TechDara is clearly a great option. It has been approved, I think, by FDA recently, and you would expect that we would achieve similar results with the other BCMA targeting bispecific antibodies like elranatamab or linvoseltamab, and we are eagerly awaiting for some results with the other bispecific antibodies in a few weeks, for instance, during EHA 2026. So with this, I would like again to thank you for your attention. Thank you for the invitation, and congratulations to the whole friends and colleagues in the kingdom and the attendees for following this lecture and for this really great event. I wish you lots of success and hope to see you very soon. Assalamu alaikum wa rahmatullahi wa barakatuh.
Walaikum salam. So I think definitely it was excellent talk and on time. We are thankful to Dr. Mohamad for his crucial time and to share his expertise. And we are lucky that in Saudi Arabia we offer CAR T cell therapy for pediatrics as well as adults. And the outcome has been presented to international forums with an excellent outcome. So I'm sure there must be some questions from our team, colleagues, so they can easily write to Dr. Mohamad for any queries and questions. For the sake of time, the mic back to Dr. Abdullah to introduce our next speaker.